Hi, in this short video, I will do a review of the anatomy of the airways. And so the objectives of this video is number one, to gain an overview understanding of the structures of the upper airway that are relevant to endotracheal intubation. Number two is to know the recommendation by the American Heart Association, CPR and the Emergency Cardiac Care Guidelines 2010-2015 on the application of cricoid cartilage, cricoid pressure. And number three is to know the Mallampati classification and the Cormack-Lehane classification. And number four is to understand the anatomic differences between the pediatric and the adult airways. And so, in a nutshell, these are the structures that make up the upper airway. The upper airway consists of the pharynx, the nose, the mouth, the larynx, the trachea, and down to the main stem bronchi. And the epiglottis separates the oropharynx from the laryngopharynx. And the function is to prevent aspiration by covering the glottis during swallowing. The larynx, the laryngopharynx extends from the level of the epiglottis, which is here, see here, colored yellow, down to the cricoid cartilage. So the top arrow, this is pointing at the hyoid bone. And this one pointing at the thyroid cartilage, and this is at the cricoid cartilage. And so this is the posterior aspect of the larynx and their relation of the various structures with one another. This is the tongue and the epiglottis, and this is the esophagus. And so the epiglottis will close up the glottic opening during swallowing to prevent aspiration. This is the posterior lateral view of the larynx. This is the posterior aspects of the epiglottis, is where you put in your endotracheal tube. And on either side of the larynx are two tear-shaped recesses known as the piriform recesses. And this is the common carotid artery, which branches off into the external carotid artery and the internal carotid artery. And you can see here, this is the structure, and this is the carotid sinus. Again, the anterior view and the posterior lateral view. The anterior view showing the relationship of the various structures. At the behind is the epiglottic cartilage, and this is the hyoid bones. This is the thyroid cartilage, and this is the cricoid cartilage. And in between the thyroid cartilage and the cricoid cartilage is the cricothyroid membrane. And the cricothyroid membrane, the height is about 1 cm, with the width of about 2 to 2.5 or 3 cm. So the larynx consists of 3 paired cartilages and 3 unpaired cartilages. And the 3 unpaired cartilages are the thyroid cartilage, the cricoid cartilage, as well as the epiglottis. And the 3 paired cartilages, the smaller ones, number 1, are the arytenoid cartilages, the corniculate cartilages, colored green here, as well as the cuneiform cartilages here. And so the cricoid cartilage shaped like a signet ring. As you can see here, the anterior aspect is shorter as compared to the posterior aspect, which is taller, broader. And so the shape of the signet ring, this is the posterior aspect, and this is the anterior aspect. And so this is the median sagittal view of the larynx, showing the relationship of the various structures. This is the epiglottis, and this is the thyroid cartilage, which has been cut off in the middle. This is the arytenoid cartilage, and the corniculate cartilage, and the cuneiform cartilage will be somewhere here. And you can see here, this is the vocal ligament, or the vocal fold, or the vocal cord, where it will modulate the frequency of the sounds in and out in order to produce sounds. To modulate the air flow in and out in order to produce sounds. So this shows the median sagittal section of the muscles of the pharynx. As you can see here, the cricoid cartilage corresponds to the level of C6. It's a complete ring, and so by applying pressure here on the cricoid cartilage, you can occlude the esophagus to minimize the risk of aspiration. Again, the median section of the pharynx, the cricoid cartilage here corresponds to the level of the body of the vertebra of C6, and so by applying pressure, you can occlude. And so this maneuver is known as the cricoid pressure or the Sellick maneuver. By applying the BURP burp method, you apply the backward, upward, and the rightward position. Applying backward and upward to minimize the risk of aspiration. Why rightward position is because as you put in the endotracheal, as you put in the laryngoscopic blade, you push the tongue to the left side, and so by readjusting to the right side, you may actually improve the visualization. But the American Heart Association, the CPR and the Emergency Cardiac Care Guidelines, way back in 2010, states that the cricoid pressure in the non-arrest patients may offer some measure of protection to the airways from aspiration and gastric insufflation during bed mask ventilation. However, it may actually impede ventilation and may also interfere with the placement of the supraglottic airway and also the intubation. And so the role of cricoid pressure during out-of-hospital cardiac arrest and in-hospital cardiac arrest has not been studied. And therefore, if cricoid pressure is applied in some special circumstances where you may suspect that there are higher risks of aspiration, you may want to consider applying the cricoid pressure during cardiac arrest. However, this cricoid pressure should be adjusted, relaxed, released, so as not to impede ventilation or to impede the placement of the endotracheal tube. And therefore, the routine use of cricoid pressure in cardiac arrest is not recommended. It's not to say that it's absolute contraindication, but the routine use is not recommended. The class recommendation is Class C, which means that the risk is more compared to the benefits. But the level of evidence is level of evidence C, which means that it's mainly based on expert opinions. This slide shows the relationship between the root of the tongue and also the epiglottis. And in between the root of the tongue and the epiglottis posteriorly is this space here known as the varicular. And this is the area or the space where the tip of the curved endotracheal blade will be positioned to during your laryngoscopic examinations. So this is a laryngoscopic view of the glottic opening that you see, and you must see this before you put in the endotracheal tube. As you put in your endotracheal tube, as you put in your laryngoscopic blade, you will see this on the superior aspects or the anterior aspect, depending on how you look at it. This is the epiglottis, and posteriorly are all the posterior cartilages, the arytenoid cartilages, the cuneiform cartilages, as well as the corniculate cartilages. And this is the tracheal opening, so you put your endotracheal tube in there. This is the vocal cords. Behind is the esophagus. So another picture showing the positions of the, and also the view and structures that you will see. The tracheal opening with all the vocal cords as well as the posterior cartilages, and here this is the esophagus. And so you, if you see these structures, you know that the endotracheal tube must be placed here and not here. This is to show the effects of doing a head tilt chin lift. Basically, is to bring into alignment the oral axis, the tracheal axis, and the pharyngeal axis so that they are as much aligned to each other. This is in order to optimize your laryngoscopic view. These are some of the important airway distances. From the incisor teeth to the vocal cords, about 12 to 15 cm, and from the vocal cord, incisor teeth down to the cranial is about 22 to 25 cm. Normally, the tip of the endotracheal tube will be about 2 to 5 cm above the cranial, which means that your endotracheal tube, the tip of it will be around 20 cm or 21 cm, depending on the size of the patient, and so the tube used. And therefore, if you use size endotracheal tube size 7 to 7.5, which is quite appropriate for female patients in an Asian population, and 7.5 to 8.0 endotracheal tube size for an Asian male. Say you put in a endotracheal tube size 7, so the tip will be around about 7 to about about level of 21 cm. You can also use the formula of the size of the endotracheal tube times 3. So if you use size 7, so 7 times 3 is 21. What happens if you put the tube, or the tip is ectocrinal? Of course, there's a risk of one lung ventilation, one lung intubation. And the other problem would be that the carina has rich in a lot of receptors that would generate vigorous cough reflexes. And so you put it about 2 to 5 cm above the carina. This picture basically shows the Mallampati classification as well as the Cormack-Lehane classification. For the Mallampati classification, ask patient to open the mouth, and for class 1, you will be able to see the entire palatal arch down to their bases, the bilateral fossil pillows as well. For class 2 is where you can see the upper part of the fossil pillows. Most of the uvula can also be visualized. Class 3 is where you can only see the soft palate and the hard palate. The uvula is not visualized. And class 4 is where you can only see the hard palate, not even the soft palate. And so you're going to have difficulty a lot of challenges that you may face in the endotracheal intubation. This is the Cormack-Lehane grading. Grade 1 is where you see almost all of the glottic aperture, the vocal cords, the posterior cartilages, as well as the epiglottis. Class 2, where you can only see the posterior cartilages and also the epiglottis. And class 3, you only see the epiglottis. And class 4, you don't even see the epiglottis. And so you're going to have difficulty in intubation again. This is based on your laryngoscopic view. This is based on by your inspection as you ask the patient to open the mouth. These are some of the anatomic differences between a pediatric and an adult airway. There are a number of them, but just highlight a few here. Number 1 is that the head to body size ratio is greater in infants and young children. This is because the head is disproportionately larger in infants and young children. And therefore, the optimal airway angulation for laryngoscopy for infants is to place towel under their shoulders. For preschoolers, you may lie them on a flat surface. And for adults, to place pillows under the heads in order to achieve sniffing positions. For infants, you just place it on the flat surface, they will naturally flex their neck. And because the airway of a small child is much narrower, small radius and small diameter, is very much prone to edema and can result in significant airway obstruction. This is because the resistance to airflow is inversely proportionate to the radius to the power of 4, according to the Poiseuille's law. And the position of the larynx for a small child is more cephalate, is at the level of C4 rather than C6 in adults. So this is a pictorial representation of the differences between the pediatrics and the adult airways. You can see they're more crowded, and the child will naturally flex his or her head when lie on the flat surface. So these are some of the important aspects of the anatomy of the airways. Do feel free to send in your comments. Thank you.